evening and welcome to the ACP Problem Solving in Oncology webinar series. My name is Paolo D'Arienzo. I'm a member of the ACP Trainees Committee and I'm a registrar in medical oncology at the Royal Marsden Hospital in London. I will be chairing tonight's session. The evening's webinar will provide you with an overview of cellular therapies for the treatment of solid tumors. The educational content of this evening's meeting are entirely non-promotional, but we are proud to have the webinar series sponsored by Roche, world leaders in oncology pharmaceuticals. Webinars are recorded and will be made available on the EBN Health ACP library website within a couple of weeks of the recording. It is free for all ACP members, and you can also access all of the ACP Problem Solving in Oncology book series within this library. Without further ado, I have now the pleasure of welcoming and introducing the first speaker of the evening. Dr. Furness is a consultant medical oncologist at the Royal Marsden, where he leads solid tumor cellular therapy service in a pan-tumor manner. He undertook medical oncology training in at the Royal Marsden Hospital, and he completed a PhD in cancer immunology at University College London. He's honorary faculty and clinical lead of the Centre for Translational Immunotherapy at the Institute of Cancer Research, London. His research interests are centered in translational immunology and the clinical application of cell-based therapies for solid tumors. Dr. Furness, whenever you're ready, over to you. Please go ahead and share your slides.
Thanks very much. Perfect. So thanks very much. That's a very polite, formal introduction, but please feel relaxed. So this is just a very informal presentation and I'm keeping it simple. So if you are in the audience and you'd like to ask questions, do, and if you don't have an opportunity in the 5 minutes or so at the end, because I think we've got about 25 minutes, I better just keep an eye on my phone. You're very welcome to contact me or ask about things in general, research and that kind of thing. So I'm going to give an introduction, although I'm mainly, and I didn't put it in the title just because it would take up too much room, to be honest, going to talk to you about TIL therapy, tumor infiltrating lymphocyte therapy. And then Fiona is going to talk to you about more sort of gene engineered approaches, T-cell receptor therapy and CAR-T, and Max is going to provide a case. So hopefully it will gel nicely together. So I used to put this slide up. This is for those who haven't done melanoma yet. This is a Checkmate 067 study, and we used to put this slide up really to demonstrate how immune checkpoint inhibitors stroke immunotherapies transform the management of melanoma. And it is, of course, it's remarkable, but actually I put it up nowadays to do the opposite, to say that it does mean that, you can take a solid tumor type like melanoma, which actually across all solid tumor types has got one of the highest response rates to immune checkpoint inhibition, yet, at least half our patients with melanoma aren't benefiting or not in the long term. We want to harness the power of the immune system. We want to do that because we think it's the ultimate tool for many reasons, but really because there seems to be an opportunity for durable disease control and possibly cure. And one of the ways that we think we might be able to do that is by using cell-based approaches. And this cartoon is an oversimplification, but I think it works well for today. And so if I bring you down to the bottom of that cartoon, you've got TIL therapy at the bottom. So TIL, tumor infiltrating, going into tumors, lymphocytes. We're talking about a type of lymphocyte called a T cell. So TILs are T cells isolated from tumors, TIL therapy first. Above it, you have TCR therapy, which stands for T-cell receptor therapy. And above that, CAR T-cell therapy or chimeric antigen receptor T-cell therapy, which Fiona will talk you through in more detail. And the reason that we are excited or think there could be promise in terms of broadening the reach of immunotherapy to more solid tumors, including those that are considered to be non-immunogenic or certainly don't respond or have minimal sensitivity to immune checkpoint inhibitors, is that there is precedent or promise if you look across into the hematological space. And so you might not think about it in this way, but if you think about diffuse large B-cell lymphoma, for example, it's not an immunogenic tumor type. If you give those patients ipilimumab, nivolumab, pembrolizumab, or combinations of, it displays minimal activity in that sort of context. Further, for those of you who've done lymphoma or have experience of it, you'll know that high-grade lymphoma is extremely aggressive. Yet, if you can identify a reliably expressed target, you can take a cell therapy here, CD19 CAR T, and you can transform outcomes for those patients. And obviously, there's many other products and many other targets that are being explored. But the principle is that you can take a poorly immunogenic tumor type and that doesn't respond to checkpoint inhibitors, and you can benefit those patients via cell therapy. And that's what we're all excited about. As I said, I'm going to focus on TIL therapy. But just before I do that, I wanted to just take you through a little bit of terminology that isn't always in the language of all medical oncologists. Some of it's completely self-explanatory, but just to start putting that language into your vocabulary, because I think for those in training, we're all hoping that for us consultants and all of us in training, more and more of these therapies may come through in due course. So the first is starting material. So those two words refer to what you use to start to generate or manufacture your product. And so in the context of TIL therapy, that will be a piece of tumor. In the context of TCR therapy or CAR T cell therapy, that will be blood. Manufacturing is sort of straightforward. I think we all know that, once you have your starting material, it needs to be manufactured into a product, and that can have varying degrees of complexity that we'll talk through in a little bit of detail later on. If I go back, that should say conditioning, I think, and that refers to conditioning the host and the tumors in the host to receive the cells. So you're trying to give principally chemotherapy still, to modulate the host, not only the tumor microenvironment, but also more broadly, for example, the peripheral blood, so that the cells that you then come in with have a better chance of getting to work against the tumor. And at the bottom, you have cell transfer, so giving the cells. And what's not sort of covered here is what happens afterwards. And there are a number of potential post-transfer approaches that you might employ to increase the activity or persistence and or efficacy of the cells that you've given. So TIL therapy, I'm going to start with. So a couple of things about it. I think the first thing to say is that TIL therapy isn't new. And many of you will know that TIL therapy was pioneered by Steve Rosenberg. It's been around since the late 80s, early 90s. And in that context, in patients with melanoma, response rates were as high as sort of 50 to 80%. And those patients will all have been immunotherapy naive or immune checkpoint inhibitor naive. But until recently, its activity in a kind of contemporary melanoma population hadn't really been explored. The reason there may be been delays in clinical implementation are that this is really complex and highly regulated. And then number two, you've had immune checkpoint inhibitors come through, which has been fantastic. But clearly we've gone back and are exploring the potential of this sort of approach. The second thing to say is that the reason we can do this, of course, is that solid tumors are solid. They have a solid tumor microenvironment that we can resect. And when you cut into tumors like this one, you can identify TILs and you can harvest them, isolate them, and then expand them up and potentially engineer them and make a product. So these are the next 5 to 10 slides are from Iovance Therapeutics. It's worth mentioning Iovance because Iovance were previously Lion, and they were a spin-out company set up via sort of Steve Rosenberg or through his work. And Iovance are probably furthest ahead, I would say, globally in terms of potentially having a product come to market. Here are the main steps that a patient would go through for TIL therapy. So procuring tissue, and we'll go into this in a bit more detail. Preparative regimen, what does that mean? That's the conditioning that we talked about, that conditioning chemotherapy. TIL therapy infusion followed by interleukin-2, a cytokine that's given in the context of this work or this trial intravenously to promote the activity of the TILs that you've transferred to the patient. And in a bit more detail, we'll go through that. So on the left, you can see a picture of a tumor. What actually happens is that this takes a lot of planning, and this is a sort of arguably the steeper learning curve as oncologists rather than the toxicities and managing that is all the regulation around this and the need for SOPs and adhering to HTA regulation, MHRA regulation, and making sure that essentially you can demonstrate the journey of the tissue stroke cell from surgery all the way through to it going back into the patient. And to protect our patients, we have to make sure that we do all of this in a regulated and robust way. It's not only regulation, that regulation includes things like making sure you're monitoring temperature at all times, following steps. It means that you have to take all of this very seriously. You have to potentially, depending on where you are in your team and how competent they are, you need to practice and do dry runs. So this isn't as straightforward as it might first appear. So we go into theatres, we take some tissue under sterile conditions into a sterile field, we tidy that up, we remove fat, we don't take tissue from necrotic areas, we give as healthy tumour tissue as we can, and we put that into a flask which has some media from it. And typically in the context of trials, and these approaches are all in trials, the flask will have come from a sponsor. And the tissue goes into the flask and it's returned to the lab where manufacturing takes place. And in that lab, you will add a cytokine called interleukin-2, which will come on to, which serves to expand up T cells within the flask, anti-CD3, which stimulates, so it's an antibodies that stimulate CD3, which is part of the T cell receptor and feeder cells. And that cocktail is used in this so-called REP, which stands for rapid expansion phase, which within this manufacturing pipeline is around 22 days. And at the end of that period, you end up with a flask full of billions of TILs. And unfortunately, it's not the case that all of those billions of TILs are going to have anti-cancer activity, but you're hoping that of those many billions, a number of them will have been expanded up to, or a number of the useful, truly cytotoxic TILs will have been expanded up to usefully higher numbers than at baseline. Patients will then come into hospital and they have their non-myeloablating or NMA, lymphodepleting or LD chemotherapy. So just to break that down, non-myeloablating meaning not ablating the bone marrow. Why? Why do we have that language? Of course, because, in leukemia, that might be something that you're trying to do, but not here. But you are trying to lymphodeplete, and you're doing that for a few reasons. You're doing it to get rid of circulating or peripheral blood lymphocytes. So you're reducing the competition when you pour into the vein your many billions of TILs, the competition for cytokines and growth factors for those TILs to expand up and then get to work against the tumor. And we mentioned chemotherapy being conditioning in general, so beyond the peripheral blood, also having activity in the tumor microenvironment to deplete suppressive immune cell subsets like regulatory T cells, myeloid-derived suppressor cells, which would potentially impact negatively on the activity of TILs once they hopefully get to the tumor microenvironment. Then you give your TILs as an intravenous infusion. Practically, what does that mean? It means what I didn't mention is that the flask of TILs at the end of the manufacture is typically put into a bag and stored in liquid nitrogen. That will come to a site and stored in a cell therapy lab, and then that will arrive to the ward in a dry shipper or a shipper, and it will be thawed at the patient's bedside. All of this, again, this is now under the MHRA, but under very regulated conditions, documenting temperature, etc., any issues with the packaging. And then those TILs are infused. And in this particular, for this particular product or TIL product, which is called Lifileucel, you then give interleukin-2 up to 6 doses intravenously. This used to be a therapy, high-dose interleukin-2 in its own right. But here you're giving a defined course, and you're giving it to promote the activity of the T cells that you've transferred. And it induces a sort of systemic inflammatory response-like syndrome, which I'll probably go on to in more detail, but is one of the toxicities that you'll see reported when you give in trials of this sort of product. And with trials in mind, I'm just going to present to you this trial, which is one of the few trials performed in a contemporary melanoma population, so advanced melanoma, refractory to anti-PD-1, refractory to targeted therapy or BRAF-directed therapy if your melanoma had a BRAF mutation. And of course, it's a trial and it's exploring the utility or activity of Lifileucel. It wasn't named at the time, but TIL therapy, a one-off TIL therapy in that population. And of course, it's a trial population, so they're not going to be perfectly reflective, but these patients had a decent number of prior therapies, a mean of 3.3, which tells you not a UK population, because you don't normally have that many, not only a UK population, I should say, and then some patients with a decent or high tumor burden at baseline, and we treated some patients in this trial, and that absolutely was the case. This slide doesn't look very exciting, but it is, and it showed that just over a third of the objective response rate to single TIL infusion in patients with melanoma refractory to all standard approaches, which is a really difficult space, where you might be looking at a few months of survival. The objective response rate was just over 35%, and still to date, so this data was originally published in the JCO and then some updated data in the JITC fairly recently, and still the median duration of response hasn't been reached, which is really exciting. So it shows you that even when you've either got acquired resistance to immunotherapy or perhaps intrinsic resistance, you can still potentially have durable disease control from a one-off TIL therapy infusion. And this is, I might try and rearrange my screen because it really is blocking off my slides. Let me have a go at what I can do. And that helps. There we go. So this is just a waterfall plot, which you're probably used to looking at, but I'm going to make it easy. So the stars are patients with BRAF mutations, and the green bars are CRs, the blue bars are PRs, the grey bars are stable disease at the time of reporting, even if they look like things are shrinking, not amounting to response. And so you can see that looks quite impressive. Decent and deep responses in a number of patients. And in terms of duration of response, you can see on the x-axis there, time at the bottom, the patients are on the y-axis. And a few things to draw your attention to, which are important. So this is all still research and clinical research, but in contrast perhaps to immune checkpoint inhibitors, it looks like when you early scans, and so at 6 weeks, you can see a lot of upside down blue triangles, which are PRs. With cell therapy in general, although a lot of work needs to be done to work this out, it looks like early scans are a reliable indicator of sensitivity, whereas that could be confusing, as you know, with immune checkpoint inhibitors. And you can see lots of those patients having PRs early on. The green triangles are CRs, and you can see some of those occurring late, which suggests that single infusion that you have at day 0 can kind of reprime or re-involve endogenous or host immunity after that TIL transfer, which is quite exciting. And you can see the blue triangles on the right with those patients continuing on study. Now, this is really important. So on the left-hand side, you've got the number of adverse events, and you can see that a majority of those fall between day 0 and day 14. Where are the patients then? Well, they're in hospital, so they're under your direct supervision. So when they're most sick, you're looking after them as an inpatient, which is quite reassuring. And then if you look over time on the x-axis, they're not really happening late out, which is quite attractive as a patient. So you can imagine, ideally, if we could better select who those 30% are, you come up to your hospital, you don't even need to live near to that specialist centre, for example, to have your one-off TIL therapy, and then you can go home once this toxicity settled, knowing that you're unlikely to have significant problems over time, not coming back up to the hospital for infusions every 3 weeks or 6 weeks, but you've had your standalone treatment. So that's quite exciting, and I suppose quite reassuring if you extrapolate this to a lung cancer population, for example, who might be a bit less fit. I mean, obviously still concerns in that population and I'm going to come on to toxicities, but it's reassuring, I guess, as a hospital clinician, that those patients are going to be under your care when they're likely to be most sick. And then in terms of side effects, so they're sort of divided up there really into two main things: cytopenias related to chemotherapy, and then the latter 3 or 4 are interleukin-2 related toxicities. And I mentioned interleukin-2, when given intravenously at high dose, induces a sort of systemic inflammatory response. So you get fever associated rigors, you can get hypotension as a consequence of sort of capillary leak. And so there is some learning to do there in terms of managing that toxicity. In the past, though, interleukin-2 used to be sort of given to maximum tolerance, and that's not what's done here. The median number was 5, the total that you could give was 6. So I think given with a sort of forward-thinking lens to how can we give this safely, or more safely than perhaps interleukin-2 used to be given before. And I haven't, just in the interest of time, I wasn't going to go into this study, but it's another recent publication from John Hannon from the Netherlands with Inge Svan and Mark Adoniya in Denmark. And this was a trial that took them eight years to complete. I thought, I should ask Fiona, I thought her colleague was involved in this too, but perhaps not. And anyway, so this was a trial that compared TILs in PD-1 refractory, anti-PD-1 refractory patients to ipilimumab in advanced melanoma. And so it was a randomized trial, which is why you're seeing it in the New England Journal of Medicine, which again demonstrated the potential utility of TILs in that setting and a superiority to ipilimumab. But as mentioned, is lifileucel from Iovance Therapeutics, so based on how things are being sort of submitted, is likely, we hope, to come through as the first solid tumor cellular therapy, that we can use over here in the Western world. When you have a treatment that works well in the refractory setting, as you know, well, typically you will trial it a bit earlier. And this COM202 study from Iovance is about that. It's about giving lifileucel, the TILs, mostly plus Pembro in immunotherapy naive patients. There are some different clinical contexts there, but this was expanded into head and neck cancer, that's SCCHN, and lung cancer in a few different contexts. And there's some data presented here. They also included some cervical cancer patients, again, naive to immune checkpoint inhibitors, in situ a couple of years ago. And so small numbers, so take this with a pinch of salt, but I'll show you the waterfall plots, which are fairly impressive. So melanoma, immunotherapy naive, metastatic disease, 60% overall response rate, head and neck cancer, nearly 40%, cervical cancer, about 57%. And you can see these waterfall plots here, which looks quite exciting. Of course, small numbers and early signs that, similar to the data I showed you before, that could be durable. So that is exciting. And although later on I might suggest there are some reasons why TIL therapy is less exciting, who knows what we will see in the trials that are going to follow. When TILs are used earlier, could they be better than ipilimumab and nivolumab in melanoma, for example? Who knows? So it'll be interesting to see how in different contexts beyond the refractory space that activity, efficacy and durability pans out. On this slide, I'm circling the sort of TIL cell expansion bits to highlight to you that what I've presented to you, lifileucel, and the study from John Hannon, is TIL therapy in its simplest form. And that has not changed since the late 80s, early 90s, as this involves taking TILs and expanding them up to high numbers with no selection step, meaning you're not trying to select out specific TILs that recognize specific antigens. You're just expanding everything up to higher numbers than baseline. And a number of you, perhaps particularly those at UCL, might have heard of Achilles Therapeutics, which is a spin-out company from UCL. And a couple of trials that are ongoing, Chiron in lung cancer, Thetis in melanoma, which is, well, I was going to say a sort of 2023 version of TIL therapy. It sort of is. So this is neoantigen directed TIL therapy. So trying to develop a TIL product that is directed against neoantigens, because we know those are important in terms of underlying response to immunotherapy or generating immune responses, but not just neoantigens, but clonal neoantigens, meaning, so neoantigens are tumor-specific mutations that are immunogenic, and then clonal neoantigens are tumor-specific mutations that serve as neoantigens that happen early in a tumor's development and remain present on every single tumor cell. So they're neoantigens that are ubiquitous. They should be on every single tumor cell. So you're trying to direct your TILs against clonal neoantigens that should be present everywhere, no matter how complex or heterogeneous a tumor might be. And so what this involves is taking some tumor at surgery and isolating the TILs, expanding them up to high numbers, freezing them down. In parallel, you take some of that fresh tumor and you sequence the DNA. In parallel, we also take quite a bit of blood in theatre, and from that you isolate the dendritic cells, which you're going to use later. You sequence the patient's DNA, and you understand of their own, so the tumor-specific mutations, which of them serve as neoantigens or are immunogenic, and which of those are clonal, meaning they should be present on every single tumor cell. then what you can do is, when you've identified those, you can generate peptides that correspond to those clonal neoantigens. You load the dendritic cells, which, remember, are professional antigen presenting cells, with these peptides, and then you co-culture the expanded T cells with these peptide loaded dendritic cells. And the idea is that at the end of that co-culture, rather than just having a bag of TILs that are expanded up to high numbers, you have a bag of TILs which are at high number, but which are enriched for clonal neoantigen reactive T cells. That's the idea. So it's more like precision sort of TIL therapy. And there, as I mentioned, there are a couple of trials, first in human studies, that are ongoing. So that's exciting. What are the challenges? There are lots of challenges with TIL therapy. I mean, obviously, many patients aren't fit for surgery. Many patients don't have tumors that are accessible. We'll come on to maybe a way of getting around that. But also, many solid tumors aren't immunogenic. So, you know, if we cut into synovial sarcoma, for example, we're likely to find very little in the way of a TIL infiltrate. And unfortunately, the rules that seem to underlie response to immune checkpoint inhibitors also, to a certain extent, seem to underlie the success or activity of TIL therapy. So we know, and you might have seen this plot before, which shows number of mutations on the y-axis and different types of tumor. And we noticed some time ago, or the field noticed, that that tumor types that seem to respond to checkpoint inhibitors had lots of mutations. So maybe those mutations were underlying, you know, how underlying the immunogenicity of those tumors. And then we know, you will have seen plots like this where you see response rate correlated with the number of mutations. This also applies to TIL therapy, and there are a couple of studies, 2 or 3 studies in this space, which have shown that patients that have more neoantigens or mutations or tumor higher mutational burden tend to do well with TIL therapy. TIL therapy is likely only going to apply to tumors that are already immunogenic to a certain extent, like lung cancer, melanoma, cervical cancer, bladder cancer. I mean, it's still a reasonable list of tumors, but it's probably not going to help many of our sort of non-immunogenic tumors. So microsatellite stable colorectal cancer, for example, or sarcomas, etc. Something that is interesting, though, and is particularly for those who might not be fit for surgery or don't have anything resectable, is the potential to identify neoantigen reactive T cells from the blood, and that would require apheresis. But there is some work here, again, from Alina Gross, who's now in Barcelona, and who was a postdoc in Steve Rosenberg's lab, doing just that. But you can imagine also those cells might be a bit healthier, given that they're not in the tumor, they're not potentially terminally differentiated or exhausted, in inverted commas. So there is lots of work going on to try and generate other neoantigen reactive products that don't start us from the tumor. And I think that's probably where I was going to stop and hand over to Fiona. I think hopefully, I think that's 25 minutes pretty much on the dot. So happy to take any questions. Fiona.
Yeah, I thought maybe we'd kick things off with a comment about John Hannon's study, and maybe a question or some context. So Robert Hawkins and myself were invited to take part in that study, but there were a number of issues with why we didn't recruit patients. Firstly, there were some financial issues around they were able to fund the actual manufacture of the cells, but not full reimbursement of the actual cost to have a patient as an inpatient for 3 weeks, etc. So there were some issues around that we could probably have overcome. But one of the reasons that it took so long to recruit to was they picked a very fixed comparator arm. They were very clear that they wanted to do a randomized study, and they picked the comparator as ipilimumab rather than saying, you know, dealer's choice, etc. So at the time when they started the study, ipilimumab was the standard of care. We didn't have combination, but by the time we were potentially going to come on board, we had combination ipi-nivo as the standard of care. It had switched. So their recruitment was initially reasonable and then really slowed during the period where we were considering coming on board. We actually asked the question of our colleagues around the Northwest anyway in melanoma about whether they had patients who had potentially received nivo single agent who would be fit enough to have ipilimumab or TILs, because obviously the patients who you give nivo to tend to be the least fit patients, whereas if you give them combination, if they're reasonably fit, they have combination, and then they were excluded. And the answer came back that we were going to really struggle to recruit. What rescued this study was that adjuvant nivo came in as an option for patients, so more and more patients get adjuvant nivo, and then obviously when they relapse, single agent ipi is a reasonable choice for those patients, always felt to be a reasonable choice, and that's what rescued the study, and that's why they managed to complete their recruitment, but why it took so long.
Thanks, Fiona. That's right, because I remember this from years ago, or I remember the study, and then it's also a great lesson in persistence and not giving up, I think.
Yes, but we probably asked you or your colleagues at the time about whether you felt that we could recruit some patients, and it was just going to be really challenging at the time.
Paolo, I'm probably have not all the right screens open. Are there any questions or in the audience?
Well, I'll make a question if that's okay. So
sure.
You were saying that, hopefully there are going to be further trials that try to move this forward toward the, first line setting and even beyond that. I think the whole process, is quite laborious and takes quite some weeks. And I can imagine, when patients come to see us in clinic after they've completed their diagnostic workup, often, they have high volume disease, and, I can imagine it being quite difficult to say, I'm going to put you on a trial where you're gonna need 8 more weeks to get your treatment.
I think it's really tricky, isn't it? I mean, it's, and you're right. It's not. It's 22 days of manufacturing, but it's, you've got to meet the surgeons. You have to be booked in for an operation. You have to be pre-assessed. All these things. It ends up taking a lot more time than you might anticipate. And the COM202 study that I mentioned to you is difficult to recruit to. So if you use melanoma as an example, those patients have metastatic disease as a new diagnosis. They need to have something measurable, something to remove, and they can't have had immunotherapy. It's quite difficult, and it's rare to find those patients, to be honest. I guess what you might be able to envisage, we do manage to do a first line study and it looks really good, but all of the things that you've said still apply, about the concern about having to wait and so on. Well, maybe then you could identify high-risk patients and you could isolate their disease, high-risk patients having surgery earlier in their disease course, and isolate their TILs earlier. I think the tricky thing about doing that, of course, is tumor evolution, and that's why the kind of Achilles approach of targeting clonal neoantigens, if that works, might be more attractive, because those should always be present. Whereas, if you isolate TILs for patients having an operation for stage 3 melanoma, some lymph nodes, actually the tumor may well be a bit different if and when it relapses. So hopefully we'll find any cleverer ways of when we harvest, when we try and generate products. And there's an awful lot of learning. The other thing is, what about the impact of the chemotherapy that you have, on subsequent response to immune checkpoint inhibitors if, you don't respond to TILs, for example? There's all sorts of unknowns there, and lots of learning to follow, not just kind of does it work or not, is it safe, but also, like you say, all the practical things too. So yeah, we will see, but you're right to highlight all those things.
Sorry, just a quick one. So you mentioned, let's imagine somebody's having a resection. Let's say, you were saying stage 3, and they have some lymph nodes resected. Then the product could be stored indefinitely in the freezer, I imagine.
But normally when you have a trial, there'll be a shelf life of the product. So normally it might be a couple of years or something like that. So you have to define in a trial protocol that you will take patients with stage 3 disease, but not stage 3A and B, which may be less likely to relapse overall. So you would have to define a population. As a sponsor, you would have to accept that there'll be patients that will never come to treatment, and you kind of hope the patients won't need it as well, in a way, but it's your safety net, if you like.
We had a couple of questions in the chat, so I think it makes sense to go through them now.
Sure.
So one of them says, if we mention the course, how much are we talking about roughly for a full course for a TCR infusion for a single patient? We know
TIL infusion. Yeah, that's tricky to answer, because it's tricky to answer at the moment without any sort of standard. I can't really give you a ballpark for that yet. And you're right. I think it's Shrikanthi's asked that. I mean, NICE will need to evaluate. If this is approved by the FDA in the first instance and then comes to EMA NICE, and they will need to look at the health economics of all of it. It's difficult to comment on that now. I don't think it's going to be as expensive as the manufacturing isn't as complex as CAR T cell therapy, for example. So, but we have to see how that does all end up being costed, and the health implications for everybody, not just patients with cancer, of course. And then there's a question here from,
I think Professor Thistlethwaite wanted to.
Yeah, just
sorry.
Fiona's fine. Yeah, no, it was just that costing thing. When we looked at the cost for TIL, and this is just an absolute ballpark, but so that you've got a kind of handle on how expensive. We're looking at, for TIL manufacture, you're looking upwards of kind of 60, 80, 100,000 pounds per just for the manufacture, and then obviously an inpatient who's in for 3 weeks having quite intensive therapy, you could probably double that, and if they end up going to ITU for a week or so, then the actual real cost becomes very significant. And then there's cost of the drugs, the IL-2, if they need drugs for their cytokine release syndrome, that sort of thing. So tocilizumab and the like.
And one final question.
Yeah, I saw that about this. So this is about the conditioning chemotherapy and about delays and how might that impact things. It would depend a bit on, well, again, just in terms of principles, these are all in trials, right? So it will depend. This will need to be you'd have to discuss that with a sponsor, and there will be guidance about what you can and can't do in that situation. But in terms of biological principles, what you want is lymphopenia. And so if you have ongoing lymphopenia, you can imagine, depending on the trial protocol, that actually you could still deliver the product, but it would depend on how much you've erred or deferred from the trial protocol and whether or not they would permit that. The tricky thing about giving conditioning chemotherapy, again, is that it is high dose chemotherapy. I suppose it depends how much they've had, but potential these patients have advanced cancer, but the potential impact on, of longer term cytopenias and that kind of thing of giving multiple rounds of lymphodepleting chemotherapy would obviously need to be considered. And it's not something that in any of the patients we've treated, we have encountered. There are often also thoughts about the patient population and doses of lymphodepleting chemotherapy, and trying to de-escalate that for patients that you think might be at higher risk, either from a renal function perspective, or there is the option, if you have early sort of lymphopenia in quite a few trial protocols, of just skipping a couple of days. There are also typically rest days and that kind of thing. So although it is sort of high dose chemotherapy, it really is about trying to induce it depends from trial to trial, but certainly a fairly selective lymphopenia. So yeah, it's tricky to answer that at this point, but it will vary from trial to trial. But the thing that you want, biologically at least, is a persistent lymphopenia. Then it would be reasonable to give your product at that point, if you have persistent lymphopenia, even if you're slightly delayed. I hope that makes sense. Slightly rambling answer, but I hope that makes sense. And And sure, graft versus host. I mean, it's your own. So the answer is not so much graft versus host. I mean, you are giving interleukin-2, so you can get things like vitiligo or other sort of autoimmunity, but this isn't sort of allogeneic. You know, it's autologous. It's your own TILs, so you're not going to. That's not going to be an issue like it would be with a allogeneic transplant.
Without further ado, we will move on to the next speaker. So it's a pleasure to welcome Professor Fiona Thistlethwaite, who is a consultant medical oncologist within the experimental cancer medicines team at the Christie Hospital and an honorary professor at the University of Manchester. She is medical director of the Christie Clinical Research Facility, and she's clinical lead for the advanced immunotherapy and cell therapy team. Her clinical practice is in experimental cancer medicine and immuno-oncology, and her academic focus is clinical trial development in immunotherapies and adoptive T-cell therapy. Prof. Thistlethwaite, whenever you're ready, over to you.
Great, thank you, Paolo. Thank you for the introduction, and thanks, Andrew, for a great talk. I think our talks are going to end up being kind of complementary. I've got some of the things that you've talked about already. I'll touch on, but actually probably in a slightly different angle. So hopefully that'll be good. And I'll try and keep to the 25 minutes if I can. And then hopefully there'll be some time for some discussion afterwards. Okay, so I'm going to focus more on the gene-modified T-cell approach for solid tumours. And I just thought I'd start with a little bit of the sort of positive and then go from there. So cell therapy, adoptive cell therapy has rapidly increased, the interest in it has rapidly increased along with the number of clinical trials. So you can see, according to this a review article, cell therapy of the immunotherapy approaches is the most commonly investigated here, mainly preclinical and early phase trials. And hopefully you can see here in the increase, a tripling from 2017 to 2019 in the number of research studies, and actually starting to see some later phase trials and even approved therapies coming through. So this is really off the back of what we've heard about from Andrew already, the key attractions of cell therapy, that idea of a living platform, a one-off treatment. You infuse the cells that can become engrafted and can overcome some of those impediments in T-cell function that we see normally in the tumor microenvironment, and the ability by activating the cells ex vivo, so in the lab, we can manipulate the patient's immune system with the conditioning chemotherapy that we've talked about. And as Andrew said already, you know, we've been looking at these adoptive cell therapies as approaches for, you know, the best part of 40 plus years now. But the thing that actually was the step change was the use of CAR-T, so chimeric antigen receptor therapies in the hematological hemato-oncology setting. So stories like Emily Whitehead, who we've seen fundraising over the years after she had early trial for CD19 CAR-T, and those long-term survivors. And this led, as we know, to quite rapid licensing and adoption in the hematological setting. And really, CAR-T, as many of you will be aware, has become really embedded now in our standard of care practice for patients with diffuse large B-cell lymphoma, some patients with ALL, but now actually moving both towards the earlier lines of treatment for those patients, but also into other settings such as myeloma will almost certainly be part of the kind of standard of care practice in the future in the UK. And so, as you know, the hematological approach has been very much focused on chimeric antigen receptors, CAR-Ts. And the early trials, we and others were looking at using antibodies, antibody fragments, SCFE fragments as the epitope binding domain, with transmembrane domain, and initially just the CD3 signaling, so linked to the CD3 signaling, and these were gene modified into T cells, so that the T cells expressed these antigen receptors. They were activated and are activated by antigen binding with activation of the T cell and subsequent T cell mediated killing. You'll probably be aware that relatively early on, additional co-stimulatory domains were added, usually CD28 or 41BB, and that's what moves a CAR from a first generation into the second generation setting. And these co-stimulatory domains increase persistence of the T cells and increase their activity, really, so improving the efficacy. And in the hematological setting, as I've mentioned already, CD19 has been the kind of proof of principle that these can really work, but there are other targets being investigated. In the solid tumour setting, there's been quite a lot of different antigens have been investigated as potential CAR-T targets. And the number of different ones actually tells a story in itself. And that is that actually we've yet to find a really good target for CAR-T in the solid tumour setting. So I'll come back to why that is, but the types of antigen that we've searched for CAR-T in the solid tumour setting include those that are overexpressed, or early on what we were looking at was mainly antigens that are overexpressed on tumours compared to normal tissue. So that's things like MART1, which is highly expressed in melanoma, but is actually also expressed on normal skin tissue. And so actually these really powerful approaches have meant that actually we see toxicity even where expression is low level in the normal tissue. So patients treated with MART1 CAR-T get really significant skin toxicity. And in some approaches for CEA and HER2, we've also seen cross-reactivity with things like for HER2 cardiac toxicity when it's used as just a kind of standard CAR-T. There's been more sophisticated approaches are being investigated to potentially overcome some of those barriers of cross-reactivity, so the CARs detecting low-level expression on normal tissue, but those are still things that are being investigated. We can search for antigens that are expressed only on the cancer and on non-essential normal tissues. And CD19 in the hematological setting falls into that category, really. CD19 is expressed on B cells. So patients who have CD19-directed CAR-T become very depleted in their B cell numbers and repertoire. But actually that can generally be managed with careful monitoring of patients and early antibiotics, for example, and if IV immunoglobulins were required. Thyroglobulin was looked at as a possibility, accepting that we may wipe out patients' normal thyroid function, but that can be replaced. But actually, these antigens in the solid tumour setting are few and far between, and it's been a real struggle to identify those. Where there's been more success, and I'll come back to in the context of TCR gene modified, is identification of antigens that are only expressed on cancer cells and or at other times during, for example, embryogenesis. And that's the case with the cancer testis antigens, where they are expressed during embryogenesis and then generally switched off. They're expressed in the testis, but that's an immune protected site, and they're expressed in certain malignancies, but relatively rarely expressed at high enough levels in malignancies, but also can be intratumoral, and so make it challenging to for the CAR-T approach, where you're looking for surface antigens only. Viral antigens are attractive and still to be kind of fully really explored in the solid tumour setting. And we know that the actual malignant tumour is made up of far more than just malignant cells. So tumour stroma components are particularly important in some malignancies where certain components are overexpressed compared to normal tissue. Now, in itself, if you just target tumour stroma components, almost all of those are expressed at low levels elsewhere, but where there may be room to explore or new technologies where we're dual targeting, perhaps with one on CAR-T, both a stromal component and perhaps an overexpressed antigen on the tumour, and by making it dual targeting, we may make it much more specific for where there's antigen only expressed in the tumour microenvironment. And we've heard already from Andrew about the possibility of neoantigen targeting in the TIL setting, but equally we can potentially identify new antigens that we can target with gene engineered approaches, but this makes it for a very unique product and increases the cost actually of manufacturing and the challenges around manufacturing several fold. And we've heard already from Andrew about actually there's additional challenges whether we're looking at gene modified T cells or TILs in terms of when we infuse cells into patients, they have to actually identify where the tumour is, so find the tumour, and that's different perhaps than the hematological setting where the CAR-T may be circulating in the same system and actually find by chance almost malignant cells. So they have to find the tumour, infiltrate into the tumour, and then survive, overcome that very immune suppressive tumour microenvironment. Just a kind of comment here, and I've touched on it already, but I think it's very easy to kind of think of all cell therapies as being CAR-T cell therapies. But we know that adoptive cell therapies fall into multiple categories, including CAR-T, TCR, gene modified, and TIL that we've heard from Andrew already. But new approaches looking at other immune effector cells, NK cells or gene modified NK cells, are certainly something that's being actively explored, particularly in the solid tumor setting, where we may be able to pull in some of the innate as well as the adaptive immune system to actually increase the power of some of the approaches. There's challenges around that, particularly with things like NK cells, where manufacturing those cells at scale is particularly challenging. I'm going to focus obviously just on the CAR-T and TCR gene modified T cells, and just to mention really, so in TCR gene modified T cells, we've perhaps seen more promising results in the solid tumor setting than we have with the CAR-Ts. So challenges with CAR-T is that there's few targets for the solid tumor setting, and those targets that exist are generally, the antigen targets are limited to extracellular antigens, so surface proteins, and only around 10% of proteins in the cell are expressed on the surface. So that straight away limits the number of options. With TCR gene modified T cells, however, the TCR is rather than an antibody fragment, is cloned to the T cell signaling domain, and it recognizes peptides rather than full proteins that are presented via HLA complexes, and that brings advantages as well as disadvantages. So straight away we can target intracellular proteins, but the downside obviously is that the TCR recognizes the antigen in the context of a particular HLA, and so far these approaches have been really limited to HLA A201 HLA phenotype. And in our Caucasian population in the UK, only about 40% of patients are HLA A201. So we have to tissue type the patients, but straight away 60% of patients are not suitable. Now, I think you can easily say, well, why not have a range of different T cell TCRs that might detect other HLAs? And certainly that's approaches that people are looking at in the future. I think to begin with, people want to find a proof of principle that these actually work with the most common HLA, and then certainly people will then search for other HLA TCRs that can identify other peptides in the context of other HLA molecules. However, what we find is that the HLA frequency of different HLA subtypes falls off quite quickly. So although 40% of patients are HLA 201, the second most common HLA type rapidly drops to below 10%. So you're looking for multiple different kind of possibilities, and that becomes really difficult. And TCRs, there's other advantages include that you can affinity enhance them to try and get them more specific for the peptides in the tumor microenvironment and perhaps less likely to cause those issues with cross-reactivity. But a downside is that there's a potential certainly for down regulation of HLA. You need HLA expression on the tumor cell, and one escape mechanism would be to down regulate HLA expression, and then the TCR gene modified T cell won't be able to see that peptide then. However, we've seen some successes. This is a paper that was published in Nature Medicine in the last 6 months from a TCR gene modified approach for a peptide MAGE-A4, so one of the tumor testis antigens in patients who are HLA-201 positive. And what we see there is the waterfall plot you can see, and as Andrew's discussed earlier with the TIL patients, an emerging really strong efficacy signal for durable responses in some of the patients. So that spider plot there seeing responses for patients out well beyond a year, but now we know significantly longer than that. By and large, so patients have to have MAGE-A4 expression for this, and by and large what we're seeing is that this is highest in the sarcomas, synovial sarcoma particularly. So it's a rare subtype of tumor, and we know that those patients are rare, but this acts as a kind of proof of principle. So we can get gene modified T cells to work in solid tumor patients. I think what we need to be continuing to work on is identification of suitable antigens, and how can we broaden this, or can we broaden this to beyond those very rare sarcomas that have very high expression of some of the tumor testis antigens. This slide actually is relevant to something that Andrew was saying. So it's a piece of work that we did because we've already mentioned that lymphodepletion it's relatively high dose chemotherapy that we use as our lymphodepletion for these patients, and not all of our solid tumor patients are fit enough to tolerate it. So there's certainly been interest in saying, do we actually need to give that high dose? Normally we give combination of cyclophosphamide and fludarabine. Do we need to give both drugs? Do we need to give the higher doses? So we did a meta-analysis actually that was published relatively recently looking at that. And one of the findings, I'm sorry that these are probably relatively small figures on your screens, but hopefully you can, the takeaway message here is one of the findings is that multiple different regimes, every trial seems to use a different or a slightly different combination of doses of fludarabine and cyclophosphamide. So you can see here each part of the pie is a slightly different regime. The blue kind of one that's about a third is the classic melanoma TIL doses. So that's a relatively high dose, but people have tried to reduce it. But what we see, these are small numbers, but it was statistically significant that actually as we see as we use higher doses of the chemotherapy, we see a trend towards increasing response rates. But also in this forest plot at the end, the higher dose regimes tend to come with significantly higher toxicities in terms, in this case, I think it was neutropenic sepsis. So there is a balance. You know, we want to use the highest dose seems to be actually probably better in the solid tumor setting, but comes with higher chance of toxicities. So not rocket science, but actually interesting to kind of in the context of our patients who are perhaps less fit. This slide, I think Andrew's covered a lot of this already, so I won't kind of dwell on it, but it's that idea that we our toxicity from the conditioning chemotherapy actually is significant in itself. And I've touched on the kind of on tumor off target, or sorry, well, both of those, but on target off tumor toxicities that we see with things like cross-reactivity. And then probably on target toxicities include things like cytokine release. one thing that is worth mentioning is that the concern around gene-modified T-cell that originally kind of was very much present. That idea that by inserting a gene, the genes are inserted usually by either retrovirus or lentivirus induction, that we may inadvertently incorporate the CAR construct into DNA that activates an oncogene, for example, and causes genotoxicity. So in this case, it would be a T-cell malignancy in patients. So for all of our patients on cell therapies who have had gene-modified cells, we have to monitor them for the potential for T-cell transformation for many years. And interestingly, we've never actually seen that. And I'm still not quite sure why that is. It's possible that the cells don't persist for long enough, that actually what we're doing is switching the immune system to be activated. But actually, we infuse billions of cells that have been gene modified, and you'd think that at some point we'd accidentally, in one of those billions of cells, activate the T cell to be oncogenically activated, but that doesn't seem to happen. And enough patients now around the world have received gene-modified T cells for us to be fairly sure that the risk, if it's there, is relatively low. Don't worry about reading everything on this slide, but it's just to say, and I'm sure you'll hear when we hear the case presentation, you'll appreciate that actually one of the biggest challenges, I think, for these cell therapies is how we would actually deliver them in our NHS setting. So we need to support the patient through a really complex pathway, and as we've heard already, from that kind of procurement and harvesting of the product, whether that's from surgical or from apheresis, through manufacture, through potentially bridging therapy for a patient, admissions, and then managing toxicities and follow up. So I think that's one of the biggest challenges. We need to actually break down some of those barriers that we normally kind of work in our silos, our medical oncology silo, and actually talking to our hematology colleagues and more, collaborating and working collaboratively with them and other teams such as the ITU team, the microbiologists, is crucial if we're going to be able to ever actually deliver these in a standard of care setting. So just in the last few minutes, thinking about where some of the kind of most exciting advances are. So one of the things that actually increased interest has generated, and the delivery of CAR-T in the heme setting has developed a huge amount of preclinical work trying to optimize these, and many of these optimization features will hopefully lead to a wider applicability for CAR-T and other T-cell therapies in the solid tumor setting. And this slide, there's not kind of time really to go through this in detail, but most of these approaches actually have resulted from the work, the new ways of engineering cells using kind of technologies such as CRISPR to be able to enhance persistence, for example, through inducible cytokines that are actually expressed by the T cells themselves. So they're gene modified to express not just the CAR, but also to secrete those cytokines in the local tumor environment, so that we can avoid having to give high dose IL-2 systemically to the patient, because sufficient of the cytokines are produced in the microenvironment. I've already also talked about things like dual CARs, where we may actually be able to have CAR T cells that can identify more than one antigen that make them much more specific for the tumor microenvironment. And then there's the ability to potentially have drug-inducible suicide switches, such that we can switch off the CAR if we're getting significant toxicity. There's been huge interest in a kind of universal CAR-T approach of using allogeneic CAR-Ts, which would allow us a more off-the-shelf product. But there we do need to think about, how we avoid host rejection of the CAR-Ts. I'm not going to talk about this anymore. This is the approach that you've heard already from Andrew around, this is actually a TIL approach, but thinking about those neoantigens and targeting the clonal neoantigens may be a very attractive way forward, whether it's through selection of TILs or potentially genetically modifying T cells. And just in the last few minutes, I want to touch on some of the approaches that will kind of be a challenge to cell therapy, but also thinking, kind of weighing up the pros and cons of these. So many of you will have already perhaps be using tebentafusp or come across this as a bispecific. It's an IMTAC. It actually has a TCR molecule that identifies GP100 and linked to a CD3 for T cell, so a bispecific T cell engager. And this has been used very successfully and shown a survival advantage in metastatic uveal melanoma. So it falls under that bispecific category that we're seeing, increasingly in clinical trials. But I think it's worth just pausing for a moment to think about these. And in some ways, these have some similarities to the T cell therapy approach, but also some very significant differences. So the bispecific approach we are seeing emerging efficacy in solid tumours. The kind of forerunner is the uveal melanoma, but there's still complex treatments that need to be given on a weekly basis. So that idea that cell therapies can be given as a one-off treatment, but that is potentially highly toxic and requires a significant inpatient stay, versus those weekly infusions that have perhaps some of the same toxicities, like cytokine release syndrome, but generally at lower grades. And those are some of the things that I think we'll have to kind of wrestle with, because it becomes about actually what's not just what's going to give the best in terms of responses, but durability of those responses, and actually how we best manage our resources that we have available to us. And talking about resources, I think just the last couple of slides, I wanted to just touch on some of the things about how we actually deliver these therapies in the clinical setting. And that's something that's been of particular interest for my work through the Advanced Therapy Treatment Centres, thinking about some of those the kind of most challenging issues in actually delivering them. So one of the pieces of work that we've done, and I'm going to skip past this slightly, but thinking about how we predict cytokine release syndrome in patients, and that's relevant to whether it's bispecifics or cell therapy. So we've done some work around using AI to identify the cytokines that are released in patients who have cytokine release syndrome, and also looking across the kind of knowledge base for CRS, what's out in the published literature, and pulling that together to try and identify predictive algorithms for being able to identify those patients who are going to have the most significant cytokine release syndrome. We're also looking through a study called Embrace at how we might monitor patients more closely in the CAR T setting with wearable technology, using AI to analyse that data and to, again, predict patients who may have worse cytokine release syndrome, where we may need to keep them as inpatients, but equally, are there patients who could be safely monitored outside in the home environment? That may become particularly relevant, for example, in the bispecific era, where some patients may need to be kept in overnight or for prolonged periods, whereas other patients may be safely discharged home. Just to go back finally to, I showed you this slide earlier of the kind of huge expansion in the cell therapy field, and I think it might be something that we could come back to perhaps in our panel discussion. Cell therapies are incredibly expensive and kind of bespoke in terms of one-off treatments for relatively rare indications at the moment. And I think what I've seen is there was a huge expansion in excitement as CAR Ts emerged for hematological malignancies. I think the landscape's changed since COVID, and in terms of the available funding for biotechs to start out to develop cell therapies. And I think we're seeing fewer of those trials coming through now than we did previously. And I think there's a question there of, do we actually continue to take on all of the cell therapy trials, or should we actually be looking for that area where we may see a real step change in efficacy, and how can we determine that? I think it's just a kind of discussion point potentially. Just as a final point for people who are interested, if you you can access some more detailed learning modules on e-learning for health, which is free. If you're an NHS employee, you can just register with e-learning for health. There's a website there where there's modules on things like CAR-T and TCR gene modified that go into a lot more detail than I've been able to today. So I'll stop there, I think, and just stop sharing. I'm conscious of time and that there's another presentation to go, but I don't know if there's time for any questions. I'm happy to answer one or two questions, or we can come back during discussions later.
Do we have any burning questions for Professor Thistlethwaite?
I was going to ask one actually, if that's all right. Fiona, thanks. It was a great talk. Yeah. It strikes me sometimes looking through some of the literature that we might be trying to overcomplicate biology with, armored cars, suicide genes. Yeah. Do you think that could be a risk of all these preclinical developments where we don't totally understand the biology?
Yeah, and in a way, I guess that's what I was kind of hinting at, sort of at the end of my talk, is you can come up with all of these things, and actually, particularly with suicide genes, I think, they're attractive in some ways, but actually, how do we manage these patients? If someone gets really bad CRS, we give them tocilizumab. We've learned how to manage those patients. So I was possibly being slightly provocative with that in saying, actually, I think we need to potentially simplify. And looking again at one of the things that we haven't done well over the years when we've had these opportunities is thinking about, say, how do we get the most out of a small trial? It costs maybe 10 million quid to do a trial in your phase 1 trial. We want to get the most information we possibly can and be able to relate that to future trials that come later. So I'm not saying we should standardize our chemotherapy, for example, but actually, if we could take away some of those variables, that would allow us to learn across different trials how important is the chemo dose that we use. If we start off with too low a dose, the approach is never going to work. So I think, actually saying, do we need IL-2? Because I don't think that's been bottomed out. Some of those really simple things are actually as important as saying, should we be adding another, armored car cytokine to the approach?
So Dr. Max Julve is a dear colleague of mine. He's done his medical oncology training at Imperial, and he's now been a clinical research fellow at the Royal Marsden for the last year and a half, working in the Cellular Therapies team. And he will be presenting the case presentation tonight. Max, over to you.
Okay, so yeah, thanks for the introduction. My name is Max Julve, and I'm Cellular Therapy Research Fellow at the Royal Marsden. I work with Andrew, and I'm going to be presenting a case of a patient that we treated with TCR receptor, or T-cell receptor therapy, short for TCR, and discuss its toxicities. So I'm not going to go over this too much because Fiona has explained it in quite a lot of detail, but essentially TCR therapy is engineered T-cell receptor therapy, and it involves genetic manipulation of autologous T-cells. And what this allows us to do is target intracellular cancer-associated antigens. And one of the most extensively investigated antigens is the cancer testis antigen, NY-ESO-1. And as Fiona explained, these have quite a unique expression profile, and that they're really only expressed in embryonic gonadal development, as well as in immunologically preserved sites within the testes. So they have really an expression profile that is extremely attractive to immunotherapeutic targeting. As well as that, they're quite ubiquitously expressed across the majority of myxoid round cell liposarcomas and synovial sarcomas. And so there's been quite a lot of product development in terms of these tumor groups and targeting NY-ESO-1. So what is the clinical need? Well, within these rare soft tissue sarcomas, firstly, they're rare, and there hasn't been much standard of care advance in recent years. And the standard first line treatment for these patients is often doxorubicin. There are some alternative chemotherapeutic agents, but they all have relatively low response rates of around 20%. There's low disease control rates and very limited durable responses. As well as this, these tumor types are considered immunologically cold, which have really increased the need for immunotherapeutic development. So the case. So it's a case of a 36-year-old female, and she was known to have metastatic myxoid liposarcoma. She was initially diagnosed in 2015 and had a right hamstring resection. She then developed metastatic disease in 2017 within the rib and mediastinum, and was initiated on olaratumab and doxorubicin from 2017 to 2019. She was then displayed progressive disease and moved on to trabectedin from 2019 to 2022. And from March of last year, she developed radiological progression and was successfully screened for a TCR therapy trial targeting NY-ESO-1. In terms of her past medical history, nothing really too significant apart from a line-associated left subclavian thrombus and a small degree of possible doxorubicin-associated cardiomyopathy with an ejection fraction of around 48%. So when we looked at her baseline imaging, she had quite significant bulky disease, and there were really three areas. So a mass in the upper mediastinum, which is around 3 centimeters, and then two bilateral abdominal masses, one in the right hepatorenal angle, which is about 10 centimeters, and one in the left upper quadrant of around 10 centimeters. And you can see on this imaging the respective areas. So in terms of treatment pathway for this patient, it's quite similar for a lot of patients on a multitude of different trials in cellular therapy. And I think it's quite important to understand what patients go throughout this pathway. And it can be quite a long process that requires a lot of logistics, and it's really it requires very intense teamwork and collaboration with different specialties. So initially, the patient has to be HLA screened, and as Fiona mentioned, this is because of the genetic engineering and the technology that has really limited these treatments for patients who are HLA-A2 positive. And this normally takes around 2 weeks to get this result. Following this, as long as the patient's positive and fits all eligibility criteria, they enter they can be booked for apheresis. And this is, at the moment, generally done in collaboration with our hematology colleagues. But it has to be noted that this is actually a clinical procedure in itself, and obtaining peripheral blood by this manner can actually be quite demanding. It takes around 3 to 4 hours. Patients have to attend a apheresis center, and there are associated toxicities such as citrate-related toxicities, such as hypercalcemia. And so it can be a relatively demanding process. And following apheresis, the blood then gets sent off for manufacture. And for this specific treatment pathway, it's a 42-day manufacture process. And the patient goes home and waits to hear about their manufacture. It's also important to note that throughout a lot of these processes, the manufacture failure rate is an issue and has to be carefully discussed with patients. Once the manufacture is complete, then the product goes into storage, and the patient essentially continues to be scanned at regular intervals until they display evidence of progressive disease as per RECIST. So now to the admission. Once the patient is ready, they get admitted for lymphodepletion. And this patient had a regime of fludarabine and cyclophosphamide. As Fiona explained, this is a fairly traditional cocktail of chemotherapy, and this is given over 4 days usually, and the cellular infusion then follows on 7 days after the initiation of lymphodepletion. So following cellular infusion, they then remain inpatient for a further 14 days before they are discharged home, as long as the patient is clinically stable and able to look after and self-care at home. So as you can see, it's really quite a significant clinical pathway for patients to go through from beginning to end that can last over a few months at least. So in terms of this patient's clinical course, so during her lymphodepletion and TCR infusions, there weren't really any immediate complications, but she was transferred to CCU post-infusion for monitoring, and that was due to her previous cardiac dysfunction associated with doxorubicin. And around 12 hours infusion at around 2 a.m., the patient developed right flank pain, rigors, persistent temperature of 38.5, slightly tachycardic and borderline hypotensive, but normal saturations. So the impression at this stage is grade 1 cytokine release syndrome. And so we really look to treat this with rather conservative measures at this stage, give aggressive IV fluid rehydration, intravenous paracetamol and ibuprofen, and really just keep a very close eye on the patient. So then the patient was reassessed 1 day post-infusion, and they have an ongoing temperature of 38 degrees, still slightly tachycardic, and the blood pressure started to drop now to 90/55. And this is resistant to a fluid bolus of 250 milliliters. And so the decision was made on the CCU to initiate a noradrenaline infusion. And at this stage, it's really progressed onto a grade 2 cytokine release syndrome. And that's because you're requiring inotrope support for the blood pressure. So at this stage, the guidance is to give tocilizumab. And so that's what we did. We gave tocilizumab, which is an anti-IL-2 antibody, and we gave it 80 milligrams per kilogram. So the following day, the patient has been given 1 dose of tocilizumab at this stage, and they have ongoing hypotension and ongoing abdominal pain. Now, the abdominal pain is relevant because some of these newer therapies, we're starting to see more novel immunotherapeutic toxicities. And this is a commonly seen side effect within this particular trial of tumor-associated inflammation. And for this, it can be quite significant for patients. And this lady, as you saw in her imaging, she had these bilateral large abdominal masses. And if you're getting large degree of inflammation at these sites, it can cause considerable pain. And so she was actually initiated on a fentanyl PCA on CCU, which added extra complication with hypertensive episodes. As well as this, she had consistent pyrexia despite the first dose of tocilizumab. And so at this stage, it's persistent grade 2 CRS. There is no hypoxia, which would make it grade 3. And so we gave a second dose of tocilizumab. So in terms of clinical course from there onwards, she actually made a very good improvement following the second dose of tocilizumab and was stepped down from CCU at day 4 following infusion. And she was discharged without further complications at day 14. So it was a 3-week admission, essentially, with significant grade 2 CRS in the week following infusion. And I just wanted to show this really, just showing the kind of blood panels we see for these patients throughout their admission. And just looking at hemoglobin, you can see that in the week following lymphodepletion and just around the days when you're actually looking to infuse, you can have significant anemia, which often requires blood product support. And then also drops in platelets. And although this patient actually had rather modest drops, and we've seen other patients which have really significant thrombocytopenia requiring daily platelet infusions for the week or so after TCR infusion and in lymphodepletion. And then in terms of neutrophils, it's important to bear in mind that these patients following lymphodepletion will really have undetectable neutrophils for at least a week or so with a nadir that's normally about 10 days following initiation of lymphodepletion. And as well as this, there'll be some significantly lymphopenic. Due to the pancytopenia, we often start these patients on opportunistic infection prophylaxis, which will need to persist for a number of months after their admission. And then by the time they get discharged, you can see that most of the counts have recovered by this stage, owing to the fact that we have given GCSF and multiple transfusions of blood products. So in terms of outpatient follow-up for this patient, she came back a week after, so that's day 21 post-infusion, and she presented with a 3-day history of gradually worsening chest pain and tightness. This is about 6 out of 10 in severity, and interestingly, it was worse at night when lying down, but improved during the day. It was also associated with a dry cough, but she was hemodynamically stable, and so we decided she could be managed as an outpatient. Did an ECG that was more or less normal, and a troponin that was less than 12, so undetectable, and a BMP that was in the normal range. A bedside echo was done by our cardiology colleagues at the Royal Brompton, and it displayed an ejection fraction which was around 50%, so around her baseline, with some global hypokinesia, again in context with her previous doxorubicin treatment, but did show a mild pericardial infusion. And this was relatively unexpected. And so the diagnosis from our cardiology colleagues was in fact a TCR therapy associated pericarditis. And she was initiated on colchicine 500 micrograms BD for 3 months, as well as ibuprofen to cover her in the acute period. And they also recommended a cardiac MRI. She showed good clinical improvement after 1 week with resolution of pain. Just in terms of her response, so on the left here, you can see a March 22 baseline. So this is prior to TCR therapy, and these 2 big bulky lesions bilaterally within the abdomen. You can see just 6 weeks after TCR therapy that there's been significant reduction in the bulk of the tumor. And what I haven't shown here is the mediastinal mass, but that actually completely resolved. And there is some thought that the pericarditis episode, due to the anatomical location of the mediastinal mass, could have been associated due to the inflammatory response locally. And then this just shows slightly longer term response. And so again, on the left, we have the baseline imaging pre-TCR, and on the right, this is 1 year and only done a few weeks ago, that shows really a really excellent response to and durable response to TCR therapy with barely measurable bilateral lesions within the corresponding areas. So I think discussion points, TCR therapy is associated with some novel toxicities, and especially as trainees in the field, we have to be constantly re-educating ourselves about what type of specialist input we need and support, and what to expect with these patients. And for this patient, it was tumor site inflammation and pericarditis that were really the quite novel toxicities that perhaps we wouldn't be that used to. As well as that, cytokine release syndrome needs to be graded appropriately and managed according to grade. And it's just important to make sure that these patients are in the right area of the hospital to be able to be managed in the correct manner. And just on a positive note, although these toxicities can be significant, the really physiologically disabling toxicities are usually seen when the patient is an inpatient in those 3 weeks or 2 weeks following infusion, which is really important when counseling patients, that they're unlikely to be going through significant toxicities many weeks after their infusion has been completed. So that's really the end of my talk, actually. So I'll welcome any questions.
I think we got a comment from Dr. Furness. If you want to go through it, Max, I think it makes more sense for you.
Sure, yeah. So Andrew has written, so to highlight further tumor site inflammation issues, look up that described with GD2 CAR-T by Strathoff and colleague. Yeah, so there's this neuroblastoma trial at UCH that I think they highlighted the issue of tumor site inflammation. But yeah, I think it's more of a educational statement than a question.
Max, what I was going to say from my end is that actually I was reassured that, you know, when I'm on call and I have the cell therapies patient in the hospital, I can get very anxious, and I see that, you know, before giving the tocilizumab, you know, they've already kind of 12 hours, 24 hours in, and having received quite a lot of fluids. You don't just, you know, as soon as the blood pressure drop and they get a temperature spike, you don't just go in with the tocilizumab. Is that because the IL-6 inhibition has, you know, potentially an impact on the response?
So yeah, I think, and Fiona can jump in on this, but I mean, essentially, we don't really know whether tocilizumab is going to have a significant effect on efficacy. From the CAR T studies, there isn't a real concern that it has significant effect on toxicity. On efficacy. But from a point of view of when you initiate tocilizumab, it really does depend on the patient. And for this patient, we were particularly keen to give Tossi to dampen down the CRS, because she had a degree of cardiac dysfunction previously. And we know that if you're having a very pro-inflammatory clinical phenotype, then it is physiologically demanding, and these patients can decompensate. And so you really do have to titrate that decision to the patient, to the individual patient. And some you would treat with tocilizumab much more quickly than others that you think might be able to continue on with CRS for a longer period of time.
I think Fiona is trying to comment. So she's saying to us that actually we shouldn't particularly worry about tocilizumab impacting the efficacy of the treatment, which I guess is reassuring for us when we see patients out of hours and we need to make those decisions. Okay, yeah, for grade 2, maybe not grade 1. Okay, so thank you very much for if there are no further questions, thank you very much for everybody involved, especially thank you to Fiona and to Andrew and to Max. Thank you very much for attending today once again, and see you next time. Thank you very much.